And it's a pleasure to participate in this webinar series. It's been about a year since I first had the opportunity to be in the webinar sponsored by Sickle Cell Anemia Awareness San Francisco, and so I'm going to update you with the things that have happened in the past year. It's been a busy year with some exciting things to tell you about. So I'm a professor of pediatric hematology at University of California, San Francisco, and my clinical practice is at UCSF Benioff Children's Hospital, where I'm a member of the Comprehensive Sickle Cell Disease Center there, led by Marcia Treadwell and Elliot Wyszynski. And my role for the past 25 years is to develop and expand treatments with curative intent for sickle cell disease. Now, I don't know that we've successfully instituted cures, but I think we're getting close. And so this is an update about where we are and what we can offer today. So just by way of quick review, as this group all knows, the source of the problems with sickle cell anemia resides in the red blood cell. And this is important because the red blood cell is the tool, the vehicle by which oxygen is delivered to all the vital organs in the body. So you can imagine if there's a defect, a problem with the hemoglobin that affects negatively the circulation, virtually every organ in the body will be affected by this disease. So we call it a multi-system disorder. So for example, if there's a blockage to blood flow in the brain, we call that stroke, and that can lead to problems with thinking and multitasking. If there's a problem with blood flow to the spleen, that impairs our immune system. And so persons with sickle cell disease are susceptible to certain kinds of bacterial infections. And finally, if there's a blockage to blood flow to a bone or a muscle or any kind of connective tissue in the body, that leads to pain, which is the hallmark of this disorder. So these are the targets of curative therapy: to prevent stroke if it's successful, to restore the spleen function, and to stop chronic pain. And so that's a tall order, but that's what we're attempting to do. Now, why is this important? Well, this is a complicated slide. It's what we call a Kaplan-Meier probability curve. And on the axis that goes up and down on the left, that's percentages. So it starts at 100% and it goes all the way to 0. And then on the other axis, the one that goes side to side, that's age of persons with sickle cell disease at the time of death. And this is an experience that's only about 5 years old, published by a comprehensive sickle cell center at Vanderbilt and University of North Carolina, led by Michael DeBond. So this is a competent sickle cell center caring for adults. So it begins at age 20. You have to be 20 to get into the clinic. And then it shows what happens over time and the median survival. So the 50% survival happens at 48 years of age for sickle cell anemia, and a little bit older, 55 years of age for hemoglobin SC or S beta plus forms of sickle cell disease. So that represents a 30-year decrement compared with Blacks in the United States who don't have sickle cell disease. So that's why, this is one reason why developing curative therapies is so important, because this is a health disparity. And we need to address this health disparity by improving our treatment and finding more treatments with curative intent. So when we think about somebody who might want to participate in a clinical trial of transplantation or gene therapy, or to get an approved treatment, each person, each family needs to weigh the clinical benefits, which is living without sickle cell disease, compared with the risks involved with getting to that. So it begins with identifying those who might benefit most from this kind of treatment, from a transplant or a gene therapy, and then asking this question: should that family decide to go ahead with the treatment or wait until after complications arise that that raise the bar for needing to do something more aggressive. How does a transplant or a gene therapy compare with the therapies that are already approved, like hydroxyurea or red blood cell transfusions, or even voxelotor or crizanlizumab, glutamine? Is a family, is a person willing to take the risks associated with this treatment? Because if not, then that really is the end of the conversation. And are there things that have already happened to the body, to the major organ systems, that make going through a transplant or gene therapy higher risk, and or not even safe? So that has to be considered. I think one of the most important things is there support in the family, psychosocial support, economic support, to get through an intensive therapy that will take 6 months to a year to complete, and which will turn one's lifestyle upside down during that period of time. So these are all things that have to be considered about making a decision about whether or not to pursue this. Here are some thoughts I'd like to share, quotes that were shared with one investigator having to do with decision making. So one shared experience was the use of terms like never allow it to happen, being leery of a bone marrow transplant, wouldn't consider an option for me. I don't want a bone marrow transplant because it's that you could die from it. So those are important considerations. Those are thoughts being expressed when thinking about this option. One parent said about her son, he's getting to the point where he's kind of sick of the pain. He wants to do a bone marrow transplant at some point. Without knowing that it's going to be 100% successful, then I would only choose it if I had to. But that's if the other options failed, like hydroxyurea wasn't working, and he was very, very sick, and blood transfusions were just starting to take over his whole life. So here's someone that really won't be ready until all the proven treatments have failed. Its risk could be like exchanging something you know versus something you don't know. One participant expressed this concern: you don't want to get rid of sickle cell and end up with something worse. And there's a risk of that happening. And finally, an adult patient said, I'm all for it if there's some very strong risk to it, and it's not the easiest process, but I mean, I still believe that's a great opportunity for patients with sickle cell. Another adult patient highlighted the risks of mortality with sickle cell disease itself. Even if it's about BMT life-threatening, I'd still do it. I would take the chance, because either way it go, living with sickle cell eventually is life-threatening. So these are, real life quotes by persons with sickle cell disease and their family considering the treatment. And this is pretty typical in my experience. So these are things that have to be worked through in the decision-making process. So finding new curative therapies. Now, I've been criticized because I've been calling these new therapies curative, and that's really the jargon, the hype that one runs into. Really, it should be curative intent, because again, I think these might be transformative in that they eliminate pain in some individuals and help with lifestyle. They're not 100% effective. So I think transformative might be a better terminology for me to use. But anyway, here's curative therapy. So bone marrow transplant ideally is performed with a brother or sister who's matched, has the same transplant type, something we call HLA identical, human leukocyte antigen identical. So the barriers to doing that kind of transplant is that only 18% of families will have that perfect brother or sister donor. And then if we were to look for a well-matched unrelated donor, we might be able to find someone another 19% of the time. So for everyone who's ever been referred to me for a bone marrow transplant, conventional bone marrow transplant, I could really only offer it a third of the time. And then lots of clinicians don't refer patients because of complications of the transplant, including a risk of dying or developing graft versus host disease. So, until recently, transplant was really restricted to children and not used very often. So the question with gene therapy is, can we modify one's own blood stem cells and have that provide an important clinical benefit? And then if we're able to do that, equally important, can we ensure there's equitable access to getting the therapy for those who want to pursue it? This was an important consensus study report from the National Academies of Science, Engineering, Medicine. So this is a big think tank in Washington, D.C. And this is a publication that was published 4 years ago now, addressing sickle cell disease as strategic plan and blueprint for action. And after a number of us participated in this process of considering what the federal government and healthcare system should do about these curative approaches in sickle cell disease, they concluded that gene therapy approaches, including CRISPR technology, which is a gene editing technology, at the time were still in development, and they are still in development, but could offer potential advantages over an allogeneic, a conventional bone marrow transplant using a brother or sister as the donor because of this problem of not having enough donors. However, there's a need for education about these approaches, and the Department of Health and Human Services should encourage and reimburse the practice of shared decision-making for patients considering these therapies, the report recommended. And then the Centers for Medicaid and Medicare Services, CMS, and state Medicaid programs. So 60 to 70% of persons who have sickle cell disease use this type of insurance, Medicare or Medicaid. These are the leading insurance for most sickle cell disease population. Should explore novel payment models and encourage and pay for coordinated care delivered by certified sickle cell disease centers, and identify approaches to financing the upfront costs of the curative therapy. So that's strong language. That's a strong recommendation. The insurance system for most patients in the United States should cover these curative therapies. So that's an important piece of advice and policy, and I'm very curious to see in the next couple of years if this is actually followed. But it's out there, and it's a recommendation from the NASEM, which is really important.
One quick question, Doctor.
Yeah.
Nancy wanted to ask, is there any research that shows the life expectancy for those who have had transplants?
Yes. Sorry, and I'm not going to show that. When we do a bone marrow transplant using a well-matched donor, like a brother or sister, in childhood, the success rate is 90 to 95%. So that's the ideal time to pursue a bone marrow transplant using a brother or sister donor. The success rate in adults using a mismatched donor or unrelated donor falls all the way to 50%. So, and that's not something that any of us would recommend because that success rate isn't satisfactory. So that's the range. And again, the results are best using a very well-matched donor in children less than 12 years of age. And they get worse the older one gets, and when one uses a mismatched donor. And so that's where we are. And I'm going to show you the results of the gene therapy trials that led to the Food and Drug Administration, the FDA approving the treatment. So you can put that in context too. So anywhere from 90 to 95% in children who have a well-matched donor to 50% in young adults who don't have a well-matched donor. And that's what we're up against. Does that answer your question?
In respect of the results, but in terms of like life expectancy, so instead of, let's say, a sickle cell patient dying at typically 30, 35 years, would that extend it out to age 40, age 50, or is that research still not
Yeah,
available?
we don't have enough follow-up to answer that question. Yeah. So
Okay.
that's the prediction, that a person who gets a curative treatment would then have a lifespan the same as not having sickle cell disease. So in the 70s or early 80s. but that hasn't been proven yet. No.
Gotcha. Okay, cool. Awesome. Thank you, doctor.
Yeah. Were there other questions in the chat? Sorry, I can't see the chat.
Yeah, no, it's fine. I just told them if they wanted clarification questions to ask that, otherwise to take notes, and we'll have the Q&A at the end.
Okay, great. So I think of an ideal cell therapy profile as something like this. It would protect from sickle cell disease related complications, both those you can see, like pain, and those that you can't see, like damage to an organ like the kidney. Acceptable short-term and long-term side effects should be accessible and available to most patients. It should be safe in both children and adults, and compared with the standard treatment, should offer a significant benefit. So that's the ideal cell therapy profile. And I'm going to make the point, and my position is that we don't have that yet. And so we need to continue to work on this and perfect it, even though we have now approved gene therapy treatments for sickle cell disease. I don't think we should stop working on this. So until we get to the ideal cell therapy profile. So this is one of the treatments that's been approved. Lentoglobin was the name for it while it was under development. It's now called Lyfgenia, and it begins with collecting stem cells from a person with sickle cell disease. So there's a way to coax the stem cells, the blood stem cells out of the bone marrow where they normally live into the bloodstream, where we can use this machine to collect the stem cells and return the other blood components back to the circulation. And once the stem cells have been collected, they're shipped to a centralized manufacturing facility where the transfer of the healthy anti-sickling globin gene is accomplished into the blood stem cell. So after the transfer, these blood stem cells have this little orange squiggle. That's the gene therapy DNA that's been incorporated into the genetic material, the DNA of the stem cell. So these are frozen and tested, and if it looks like they're safe for clinical use, they go back to the transplant center where, after giving a single chemotherapy drug called busulfan that wipes out all the blood-producing cells in the body, these frozen gene therapy stem cells are then thawed right there at the bedside. They're given just like a blood transfusion, and then there's monitoring for the outcome over the next 2 years in these studies. And this is a cartoon off here to the lower right-hand side of how that anti-sickling gene therapy globin works. And what it does is it has this little side chain to one of the components of the globin molecule that interferes with forming these long strands that, after the oxygen is delivered, form in the red blood cell to give it that characteristic elongated shape that's really stiff and blocks the circulation and causes pain. So this gene therapy globin is designed specifically to not allow that to happen. And so the other approach, and this is the product called Casgevy, is a little bit more complicated, and but relies on the CRISPR technology. So CRISPR is a new tool that, like a spell checker, will scan all of the DNA sequences in the blood stem cell to find that needle in the haystack, unique DNA sequence that it's been engineered, designed to find. And what it does is, once it finds it, it creates a break in the DNA, and it disrupts a particular region in the DNA. And then when it's brought back together, that disrupts the action of that region. So this is a molecule. Its name is not terribly important, called BCL11A. But what it does is, at birth, so before birth, we make fetal hemoglobin. And the reason why is that in the womb, obviously the fetus, baby in the womb, can't breathe air. It gets all its oxygen from mom's circulation. So mom, an adult, makes hemoglobin A, adult hemoglobin. The fetus in the womb makes fetal hemoglobin. So the oxygen binds more tightly to the fetal hemoglobin. And so that's how oxygen is transferred from the mom's circulation to the developing babies. So that's important before you're born, but after you're born, you don't need that anymore, and the fetal hemoglobin turns off. And the reason why it turns off is because this protein called BCL11A actually binds to the fetal hemoglobin gene and turns it off. Now that this has been disrupted by the CRISPR treatment, this protein isn't made anymore in the red blood cells, and the fetal hemoglobin, instead of turning off, now stays on. And we know that's important because in persons who inherit a change in their DNA such that the fetal hemoglobin doesn't turn off at birth, we call it hereditary persistence of fetal hemoglobin, and they inherit sickle cell disease, they behave like they have sickle cell trait. They don't really have sickle cell anemia. So we already know from nature that raising the fetal hemoglobin improves or eliminates sickle cell disease. And in fact, that's one of the purposes of the hydroxyurea, to raise the fetal hemoglobin and interfere with the side effects of having sickle hemoglobin in the red blood cells. So here's the Casgevy CRISPR approach, and that's the rationale for why it was developed. And so this is information from both of the clinical trials that led to the FDA approval. And each, I'm going to call these swim lanes, represents one patient who participated in the clinical trial. And in the panel on the left for Lyfgenia, each painful episode is depicted as a red dot. And so you can see in the 2 years before they got the treatment, there's lots of red dots in all the swim lanes. So to be eligible to participate in the clinical trial, one had to have a fair amount of pain. And then after the transplant, depicted in light blue, is the time with the gene therapy stem cells in the circulation. And you can see that the red dots disappear in many of the patients, and in fact, disappear completely in 32 of 34 of the patients. But even those who still had some pain, it was much less frequent than before they got the treatment. The Casgevy is the same idea. Each lane, if you will, represents one patient. So lots of blue dots representing painful episodes before the treatment. And in all but one of the patients, in the time that this was measured, in up to 18 months after the infusion, only one of the 29 patients who were evaluated still had pain. And this other patient developed an episode of pain, but you can see a markedly decreased incidence of pain. So this result, I think, is remarkable. It shows that either treatment with Lyfgenia using a gene transfer for an anti-cycling globin gene, or Casgevy, which uses CRISPR technology to turn on the fetal hemoglobin, is effective at eliminating pain in 90% of the patients. So that's the hype, that's the excitement. But what bad things can happen? Well, here's a very scary bad thing that happened. And two of the first patients treated with the Lyfgenia product, actually, this was before improvements were made in how the stem cells were manufactured. Two of them developed leukemia. One about 3 years after the infusion, and he died of leukemia. And the second one, 5.5 years after the treatment, and also developed leukemia that was fatal. Now, in the first patient, no gene therapy DNA was found in the leukemia cells, which means that the gene therapy DNA did not trigger the leukemia. But there was certainly something about the treatment that did, and that's still not completely clear. And in the second patient, there was gene therapy DNA in the leukemia, but it had landed near a gene called VAMP4 that doesn't cause cancer. So again, in neither case did the gene therapy DNA trigger the cancer. So there's something about the treatment, and Lyfgenia in particular, maybe, that accelerated the likelihood of getting a leukemia. But I would argue that there's a risk in both of these approved treatments that has to do with how we do the transplant. starting with a fairly small number of stem cells and reforming the entire blood producing system in the body. And there's something about that in sickle cell disease that could lead to the formation of a leukemia in some patients. And so we're trying to screen everyone for this risk, but since we don't know exactly what causes the problem, it's not really clear yet if the screening is going to be successful. So that's something everyone has to consider when they're trying to decide about whether to pursue this treatment. So here are the approved treatments for sickle cell disease, and we do have them available now. Both Lyfgenia is available, and I think Casgevy will be available at the end of the summer. Both appropriate in our center for persons 12 to 30 years of age. So we're not treating children less than 12. And at our particular institution, we can't go past the age of 30 years, although it can be given to adults who are older. It's just that I can't do that at a children's hospital. And this is what it looks like on their website. So Zynteglo is the same thing as Lyfgenia, except that it's for persons who have thalassemia, which is a different hemoglobin disorder treated by blood transfusions. And then Casgevy is approved for both of those disorders, sickle cell disease and thalassemia. Zynteglo for thalassemia, $2.8 million. Lyfgenia, $3.1 million per person. And then Casgevy, I guess a bargain at $2.2 million. So these are incredibly expensive new treatments. They're available, but the insurance has to agree to cover the cost. So that's a daunting problem. And then the Lyfgenia, I told you, has this risk of getting leukemia, and there's actually what's called a box warning. So hematological malignancy, that means leukemia, has occurred in patients treated with this product. So they should be, each person has to be monitored for the development of leukemia after the treatment. So the cost.
Sorry to interrupt you, doctor.
Yeah, go ahead.
Very, very quickly, the 2.2 and the 2.8 and the 3.1, is that per patient or is that per? Okay.
Per patient. Each
Gotcha.
patient gets one dose of this gene therapy cell product, and that's what it costs.
Gotcha.
And in addition, that's just to get the cells. We have to cover the cost of getting you through a transplant. So that's another $100,000, $200,000 usually to do that. So it's a very expensive process, and it must be covered by one's insurance, which I mentioned for sickle cell disease is going to be Medicaid or Medicare 60-70% of the time.
Right. Have there been any instances where so far in the preliminary studies that show people needing multiple doses, or is one dose just enough?
Yeah, one dose is all we can deliver.
Okay.
And it, it's been successful most of the time as far as eliminating pain. Does it protect from all aspects of organ injury? That we haven't established. That's still something that we're learning about.
Okay. Thank you, doctor.
Yeah. So I think we still have work to do, and so I'm involved with 2 active clinical trials that are not approved yet, just getting started. One of them, one's from a company called Editas that also uses a CRISPR technology to induce the fetal hemoglobin, to reactivate it. And when I made this slide, it was active in 5 to 12 years of age. And I think, unfortunately, all those slots have been filled. So I believe this study is about to close. And then a study that I'm starting this summer, that's just getting started, will enroll adults, up to 6 adults, with CRISPR technology that's directed to correct the sickle cell disease mutation directly. So the first time anyone has attempted this in adults. So this is the Editas trial, and I just want to quickly show some results. So um, these are bar graphs that depict the average amount of hemoglobin being made after the treatment. So before the treatment, the dark blue is hemoglobin A. So these are individuals who are getting red blood cell transfusions in preparation for the treatment. Here's the time where they got the treatment, and then this is the time afterwards. So hemoglobin A is blue and hemoglobin S is orange. And here are the hemoglobin levels, 14 to 15 by 10 to 12 months after the treatment. And it looks just like sickle cell trait in that there's about 40%, 50% sickle hemoglobin mixed with fetal hemoglobin in each red blood cell. So these persons have not experienced pain. Their anemia obviously has been taken care of with hemoglobins in that range, and they behave clinically as if they have sickle cell trait. So this is CRISPR technology, and I think the results have been really quite good in 18 patients, mostly adults who've received it. So and I like this treatment because it makes changes in the DNA that are exactly like those changes that occur naturally in the condition called hereditary persistence of fetal hemoglobin. So it's a change in the DNA that we've already learned through nature is safe. So that's something that's coming uh, out in the future that I think will be approved and available. And then the study I'm doing uses the CRISPR technology. So this is a cartoon where this is a section of DNA, let's say, that has the sickle gene, sickle mutation, I should say, in red. And the scalpel is the CRISPR technology cutting out the area that has the mutation. And then with the forceps, inserting in an equivalent piece of DNA. It has the same sequence, except that it doesn't have the mutation. So it's the healthy hemoglobin that's being inserted. Now, this is not nearly as efficient as occurs in the two other treatments that have been developed, where instead of inserting the right sequence, the treatment so far with CRISPR has just been to make a double-stranded break and then allow the cell to close the ends. And that will inactivate how that protein called BCL11A will change its ability to stop the fetal hemoglobin from being made. In this case, this reaction only happens 20 to 30% of the time. And the key question will be, is this effective? Because you're only going to correct the problem and 20 to 30% of the stem cells were given back. Now, the other thing that will happen when this swap in doesn't occur is that the cell will just close the two ends, and then it's missing a key piece of DNA to make hemoglobin. So that then becomes a cell that now has thalassemia, which is the other blood disorder where not enough hemoglobin is being made. So there's a risk that instead of correcting the disorder, we'll actually create a new one called thalassemia. And the purpose of this study is it's an experiment. Is this safe and effective to do? Can we do this safely? And can the treatment be effective? And that's the purpose of the clinical trial. So specifically, do the stem cells work properly after this gene editing reaction has occurred? Does the gene editing lead to a new problem, thalassemia, with its need for transfusions, or could it cause a blood cancer? Effectiveness, are there enough edited cells to stop pain and other sickle-related problems? I told you that we think this is only going to happen 20 to 30 or 40% of the time. Is that enough? And then, is the benefit of the treatment long-lasting, which is true of all these disorders? And the reason why I prefer this one is because in those other treatments, if for any reason the treatment effect wears off, they still carry the original sickle cell mutation. And in this treatment, that can never happen because we've basically corrected the mutation. It can't ever come back. So so these are key questions that we'll be asking in this small clinical trial. It's what we call a phase 1 clinical trial, really focused on safety in the next several years.
Doctor, along those lines, there was a question asked, do the transplants help reduce or limit organ damage?
Yes, they do. But they limit new organ damage. What we've learned in most organs, except for the spleen, what doesn't happen is the organs, if they have damage already, that doesn't get better, it doesn't get repaired. So it's another reason to think about this before a person has developed, significant organ injury. So, for example, if somebody has a pretty common problem called avascular necrosis, which is damage to the hip or shoulder from sickle cell disease. That doesn't get better after a successful bone marrow transplant or gene therapy. So if you go into this with avascular necrosis and your doctor has already said, well, you're going at some point you're going to need to have a hip replacement surgery, you'll still need to go through that surgery, even if the gene therapy or bone marrow transplant was successful. So, so that's an important question. I'm glad somebody asked it.
Awesome. Perfect. Thank you, doctor.
So just to finish, I think these are the key questions for the future of gene editing for sickle cell disease. Is there a risk of leukemia or cancer? And what are the long-term outcomes? Because right now we don't understand them very well. Will the cost and complexity of delivering this treatment restrict access to care? Will it be impactful, or will it, because of its limited availability, have limited impact? And then finally, do we have an improved ideal cell therapy for sickle cell disease? I argue that we don't yet, and we need to keep working on this. We've had some great success and it's exciting, but we can't stop. We can't rest. We need to continue to do better and to find that ideal cell therapy for sickle cell disease. And then I just like to finish with the funding that I've received both for the California Institute of Regenerative Medicine and the Cure Sickle Cell Initiative through the National Heart, Blood, Lung Institute at NIH. Thanks.
Awesome. Thank you, doctor. We appreciate it. Great presentation. A lot of information. I got a ton of questions myself from some of it. But let's go ahead and get started with anybody else at this moment. If you have any questions that you feel are pressing, go ahead and unmute yourself and introduce yourself and go ahead. If not, I can get the ball rolling with my first question. Something that you brought up that one of the patients did mention is if you were to get rid of sickle cell completely, or if in doing the therapies something happened that it just all of a sudden disappeared, what could be, like, in your professional opinion, something that could develop to kind of replace that, or would there be anything that replaces it? Would your body just be normal after that?
So I don't know if this answers your question, but one of the forms of CRISPR technology that's under development is to do that reaction without making a cut of the DNA. So there's way just to nick the DNA and replace a single DNA nucleotide, a single part of the code, and that would probably be safer than what we're doing currently. And so that's the sort of technology that's being explored. The other thing is that I didn't tell you is that I mentioned briefly that you have to get this high dose chemotherapy, which has a lot of side effects, including infertility, which is a big problem, particularly in children when we can't really like harvest sperm or eggs before puberty. So so one of the things that's also being worked on is, can we do this treatment without high dose chemotherapy And can we do the editing directly in the body instead of having to extract the cells, ship them to a manufacturing facility, pay millions of dollars to get a dose? It would be a lot cheaper just to inject the CRISPR tools directly in the bloodstream, direct them to the bone marrow where the blood stem cells reside, and do the reaction there. And then no chemotherapy or very little chemotherapy we predict would be needed. So those are some of the exciting areas of research that are going currently that I think will address some of these problems.
Yeah, for sure. No, that's a great answer. Awesome. Anybody else? Okay. Another follow-up that I had, doctor, for you is could you go into further detail about curative versus transformative? I know you said you got some kind of kickback or talk back when you talk about it being curative, and it should be maybe better labeled as transformative.
Yeah, as an example, so a lot of adults develop chronic pain where they have pain every day. They have to take pain medicine every day, and it really anyone who has this knows that it really has an impact on the activities of daily living, quality of life, so forth, ability to control your future. And so we've treated individuals who have that kind of pain every day, and it doesn't go away immediately after the treatment. So there's something about the nervous system that gets completely restructured in sickle cell disease that isn't fixed immediately with one of these treatments. It does get better, but it tends to take months and months and months, and gradually gets better and finally goes away. So, I would think a curative treatment would, take care of all aspects of the disorder, including the chronic pain. And this does eventually, but it doesn't right away. So that's an example of, our overhyping what this might do for, a person with typical sickle cell disease. Definitely gets better, but it's a long process. And so, we just have to be clearer about expectations.
Gotcha, gotcha. So it's more of the timing thing, the short span versus the long picture.
Hey,
Awesome.
I have a really quick question. It's a very helpful talk, so thank you so very much for giving it today. I appreciate it very much. I just wanted to explore a little bit more about if somebody is 30 years old right now, you still would accept them, or
Yes.
what would their other options be? If they haven't really decided quite yet,
Yeah, there
where
are. Yeah. Well, I can accept anyone who sees me before they turn 31. So I've treated a 31-year-old actually, because he got there under the, but but honestly, there are other institutions. University of California, Davis, for example, has an adult bone marrow transplant program that's going to be able to offer these treatments to older individuals. University of California, Los Angeles, the same. So it's just that unfortunately at UCSF, we haven't, it's something we're working on, but we haven't carved out enough space in the program for adults because they're so busy treating other disorders to expand into sickle cell disease. But we will eventually. But that's and there are options. Unfortunately, they're just not at my institution right now.
thank you so much.
Yeah.
So one question that Nancy had, doctor, are there currently any therapies that avoid using the chemotherapy that is such a challenge?
Right now, no, there are none. And when we use lower doses of the chemotherapy, this has been tried in one of the gene therapy trials, doesn't appear to be as effective, unfortunately. So, so the treatment effect gets diluted out by the sickle blood stem cells that still make sickle red cells. And so that, unfortunately, that's where we are today. So no, there's no, now there are disease modifying therapies and they're under development too that they're not they don't have a curative effect, but they are still important. And of course, those are certainly available, some of which are FDA approved and some of which are under development.
Thank you for that. Any other questions? It seems Nancy has her hand up. Go ahead, Nancy.
Yes. First of all, thank you so much for giving us this great information. You really seem to have, real insight into what the kinds of things that are going on with people. And, I've heard people say, well, don't worry about infertility because if you're an adult, we can freeze sperm or egg and then you can do whatever. People don't have thousands of dollars to freeze anything,
Yeah.
And certainly if they're going to be off of work for months and months, now they have even less money because I just don't see anybody's insurance company paying any kind of a living wage to them while they're taking part in this. So that's one of the biggest issues, is that it's just not feasible for so many people. And of course, right now, I think people would be very reluctant. But I will just say, should you need a person that is kind of a community or patient advocate in your group, I'm going to raise my hand. I have been an advocate on various other CERM groups with Dr. Cohn at UCLA. I'm a patient community member at Cedars-Sinai, not for sickle cell, but just for their safety stuff that they do. So please give me a call. I'd be honored to work with you.
Okay. You're on record. I'm gonna follow up.
Good.
Now we have the sickle cell anemia awareness San Francisco liaison is just one of several that we have. We've been working with Cayenne and Access and so other community-based organizations. And I actually, I think this is so important that I actually added a team member on the team under salary just to do awareness and social outreach. So her name is Christelle Solomon. She's participated in some of these webinars with me, and she's a warrior. She actually went through a bone marrow transplant a few years ago. So so she's a great spokesperson and leading that effort. So we're just not going to make any progress. I'm with you, Nancy, if we don't take into account all these aspects of what it takes to get through this treatment, because it's daunting, and we're just not going to have the impact we need to have. So they have to go hand in hand.
Again, thank you so much.
Yeah.
Dr. Karen just asked, is there a way to reach you to schedule an appointment? She was interested for her son.
Yeah, I'll put my phone number in the chat. And the best way is to call this number. Or if you Google sickle cell disease gene therapy at UCSF, you'll find our website that describes, and then there's contact connection there. The UCSF has a list of all active clinical trials at UCSF, and if you search for sickle cell disease, there's a way to send an email to me directly, and then I'll have a team member follow up. But there's the phone number. That's probably the fastest way to get things started.
Awesome. Perfect. Thank you, Doctor. Yeah, so if everyone can refer to the chat, he has posted his phone number there, as well as the Google search you just mentioned, or going to UCF Benioff.
Or I'll put my email address too in the chat. So either way, whatever's easier.
Are there any known side effects of the infant hemoglobin being in your system at past a certain age?
Yeah, so the question that comes up the most often is if if you're a female and you want to start your family, will the oxygen still get transferred to to the developing fetus in a person who's just making the fetal hemoglobin, because how will the oxygen, and the answer is yes, the oxygen does transfer. You can have a healthy pregnancy. So so no, we don't really know of any significant health related issue caused by having fetal hemoglobin as an adult.
Cool. Awesome. Okay, any other questions? Anything burning, people? But I noticed on the mutation of the orange squiggle line that you mentioned, that's so how exactly is that developed? And then is there any plausible scenario or anything in the research that's shown that that mutation can actually mutate within itself before it's actually implanted to the person?
Yeah, no, it's pretty stable.
Awesome. Perfect. Cool. That's all I had.
All right.
Okay.
Well, thanks for having me. It's always a pleasure. Let's get together next summer too, and we can share what we've learned in the next year.
Yes, for sure. Thank you, Dr. Walters. We will go ahead and reach out to you for next summer.